Dear ESTS members and webinar attendees, my name is Lieve de Piepere, your moderator for today. This webinar is the first one of the fourth season in the ESTS educational webinars. These webinars have more than 3,300 unique registrants in more than 75 countries worldwide. I would like to remind you just on the questionnaire about the educational webinars that has been sent to you. The ESTS Learning Affairs Committee wants to know your opinion on how we can even improve this successful formula. Thank you for taking some time to fill out this questionnaire. The subject for today is the management of esophageal perforation and leak. As shown by a new massive subscription today of about 500 registrants, this will be again a fantastic journey led by a true expert in the field. I'm very glad to introduce you to a man we all know as our former Director of Education and the current Secretary General of the ESTS. Professor Hasan Batirel is consultant thoracic surgeon and professor of thoracic surgery at the Marmara University in Istanbul, Turkey. Professor Batirel has always had a special interest in esophageal diseases and was one of the first authors to publish on uniportal transthoracic access to the esophagus. Therefore, I think he's our ideal guest speaker for today. We will ask your interactivity, so be ready to answer the poll questions, and please ask as many questions to the expert as you want after the expert talk. Professor Batirel, the stage is yours.
Thank you, Lieven, for your kind introduction. It's an honor to present in this webinar, first webinar of the fourth year. It's always a pleasure to be involved in the educational activities of ESTS, which reaches out to the globe. So I will share my screen now to start with my presentation. So my topic today is on management of esophageal perforation and leak. And I will be starting with esophageal perforation.
You just don't have the speaker's view yet.
Sorry?
So we can see your presentation, but we don't have the speaker's view yet.
Okay, now I will, can you see it now?
No, it remains the same.
Okay, 1 second. Is it okay?
No, it remains the same. Did you share your...
Just 1 second, I will try to do it. I will try to do it in a different way. Is it okay?
No, it remains the same.
1 second.
I think it takes your presentation and not the screen.
Okay then, 1 second.
Uh-huh.
I will do like this. 1 second. I will do it and then share it with you.
Mm-hmm.
I think it should be no. Okay, is it okay now?
Perfect.
Okay. So I will be talking about the management of esophageal perforation and leak, and I will start with the esophageal perforation. And let's start with the first poll. How many esophageal perforation patients do you treat every year?
So for the people who didn't do this yet, in the right sidebar, you can see questions and polls. If you go to the polls bar, you can see the first question: how many esophageal perforations patients do you treat every year? And you can vote there. You can vote now. I see that We already have half of the audience that voted, so some people can maybe vote. It's anonymous, so it's no problem. Just to have an idea on what you are doing. Okay, so we have 70% of the audience that is treating less than 5 patients with esophageal perforation. About 1 in 4, 6 to 10 patients, and let's say less than 5% is treating more than 10 patients.
So this is a very nice reflection. I think it shows that this is a rare situation in the management. So we have so gaining experience in this rare situation really takes many years, and to be used to the presentation and the outcomes of management choices takes time, and that's the main reason. Most of us treat less than 5 patients every year. You very well know this famous story about the Dutch admiral who had a feast of food and then did an intentional vomiting, cardus benedictus, and then said, I tore something inside, and he was fatally right. He died 16 hours later, and it was proved by autopsy, and the name was through Dr. Herman Borja. And as you can see, the etiology lies mainly, it's iatrogenic. The famous Boral syndrome accounts about 1/5 in some series, about a quarter of all the perforations. There's several reasons, from iatrogenic trauma, foreign body tumor, and others. And did it change at all? This was from 1992 from Dr. Ginsberg's report. But did it change much? Well, you can see this relatively recent series, about 80 patients. Still, most of them are iatrogenic. Only 10 patients out of 70 were spontaneous perforations. Obviously, for an esophageal perforation, you need to have a high index of suspicion, especially if the patient has subcutaneous emphysema after an endoscopic intervention, or a pneumothorax after vomiting, forceful vomiting, or odynophagia, sometimes even pain when swallowing, and sometimes pleuritic pain if there's free flow to the pleura. And obviously, these patients, if they have perforation, they will have malaise and feeling sick, and might have a low grade to frank fever. And the preoperative evaluation, nowadays we don't do barium, but most of the water soluble contrast will extraluminally leak, but you can certainly see on a CT scan, which is available every day, the thickening of esophageal wall, periesophageal air and fluid, mediastinal inflammation, effusion, and emphysema. So the next question would be, do you follow a specific algorithm guideline in the management of esophageal perforation leak?
There again, you can vote in the polls bar. This is going well. Half of the audience voted already. You can have some more votes, I think. Just click yes or no. It's anonymous. Okay, this is interesting. About 60% is saying no, we don't follow any guidelines, algorithms, and about 40% is saying yes.
Yeah. This again is a very good reflection that we lack guidelines or specific algorithms. There are many in the literature, but they fail to attract the attention or adoption of many of our colleagues. You must be, I'm sure you are well aware of the paper in 2009 by Dr. Abbas from Pittsburgh with Dr. Lukatit's group that actually developed a scoring system for the severity of perforation to predict the outcome and the complications. And you can see the points that is given for each status, such as age, tachycardia, leukocytosis, effusion, fever, sometimes a frank leak in barium swallow or CT scan, respiratory distress, and a 24-hour, more than 24-hour admission, and eventually 3 points for cancer or hypotension, which is most likely a septic shock. So think about a patient who comes into the ER with some respiratory distress, like tortured breathing, like 2 liters on oxygen. Usually they have tachycardia, so it's 3 points. And if it's 48 hours after the event, it's already 5 points in the score. And you can see in this paper that if you have less than 2, which means you just have leak and nothing else, or you just have tachycardia and nothing else, and the mortality is low in these situations, but still there is a significant complication rate, almost 50%, and the patient is hospitalized for 10 days. But as the score goes beyond 5, which is really common also, then the complication rate goes to 80%, and the mortality is over a quarter, which is very, very significant and high. And there have been several papers, very good papers in the literature from Germany, from my colleague in Erzurum in Turkey, Attila, and Dr. Erol and Dr. Lukitic, and they showed that if the patient admit after 24 hours, the mortality rates were over almost 20% or higher. And when you look at the overall mortality of esophageal perforation, it's still significantly high. About most are over 10%, which is very significant. And did it change at all? When you look at 1992 paper by Dr. Ginsberg, the mortality was 22%. Obviously, there is some reduction, but still the situation is very grave and very significant. And you can see in this paper from Dr. Schweigert from Germany, who actually compiled a group of patients from multi-centers in Europe, that showed that the perforation score didn't change much over the years. The admission time didn't change much at all, but the patients got older. The operative management decreased a little bit with increase in non-operative management, and the morbidity increased most likely due to the age. And the use of stents increased significantly, and the mortality didn't change much, which was almost 20%. And you can see another report from other series that the surgical management and conservative management were different in terms of mortality, but still the groups are very different. So you have more Boerhaave in one group and less in the other group. Or time to treatment is very different. When you look at the surgical group, 80 hours time to treatment. When you look at the conservative group, it's 58 hours, which means you have 0 mortality versus 12% mortality. And it's pretty much the same when you compare the stents and the surgical groups, which means that the injury size may be similar, but the ages are different. So younger age group in the stent, elderly, more elderly in the surgical group. Obviously, there was a significantly high mortality in the surgical group, whereas much less in the stent group. And this was also another. This also showed that the choices in terms of stents is increasing, but pretty much there's not an extreme change in the preference of different treatments. They are relatively stable. The overall mortality of esophageal perforation is coming down, but still exceedingly high. You can see that the 30-day mortality is about 35%. This is, again, a national mortality. And you can see that the 30-day mortality is 25%, 90-day mortality is almost 35%. This is mainly due to the high complication rate. If the pleura is contaminated with gastrointestinal secretions, you almost always get a pneumonia and respiratory sepsis. You may need ventilatory support. Obviously, you will need some interventions, usually multiple, from chest tube drainages to VATS or even thoracotomies, and eventually the patient even may need an esophageal reconstruction. This was a management algorithm in Dr. Schwager's paper in 2016 that showed a low Pittsburgh's severity, perforation severity score group, which means if you have a simple conservative management, if it's just a contained leak, if it's a medium group between 3 and 5, and if the presence of cancer is important. So there are three main important things. One is if the leak is contained or not, if there is associated esophageal cancer or not, and if the underlying esophagus is healthy or not. So you decide based on these things. If there is an esophageal pathology such as subtotal destruction, as you can see in the medium group, or pre-existing esophageal pathology, most of the patients will go for esophagectomy. And obviously, if the patient is fit for aggressive treatment. Now, just a different case. We always focus more on the thoracic perforations, but this was a patient 6 years post-chemo radiation with total obstruction of the cervical esophagus, and then we tried to open it with an endoscopy and esophageal gastric endoscopic intervention. We were not successful, and we forced it too much, and it's obviously we have now a perforation that's going down to the mediastinum, and some pneumonia already starting in the right superior segment, and some reactive left effusion. This patient was only drained with effusion and a JP drain from the cervical area. And now let's ask the third question. Do you use Pittsburgh severity score or perforation severity score in evaluating esophageal perforation patients?
I'll wait a few more seconds that people can vote. About half of the audience has voted. The other half can still do that. Okay, so 4 and 5, 80% is saying never used it. And almost all the rest is saying sometimes. There's only 2% saying routinely.
Yeah, so it's obvious that we try to evaluate patients individually. So this was tested in a nice paper from Birmingham, if PSS worked all the time. And they found that it works to predict the outcome in Boerhaave syndrome, which was the predominant pathology in Dr. Schweigert's paper, but it fails to predict the outcome in iatrogenic perforation, where perforation is due to other etiologies. Well, obviously, depending on the site of the perforation, there are several techniques that you can use: drainage, stenting, reinforced repair, T2 fistula, exclusion, diversion, even esophageal resection. And especially intrathoracic techniques involve the debridement, drainage, double layer repair with reinforcement with pleura or muscle flap. T2 repair can be done if the esophagus is not healthy and you cannot suture the esophagus well, and it's a good location just over the diaphragm so that there's a controlled fistula. And esophagectomy can be done if the esophagus is not salvageable. And when you look at this paper from France in 2004, the Boerhaave mortality was 24% in 25 patients, but the management principles didn't change much. You need to wash pleura and mediastinum. You need to double layer close the mucosa and the muscle and buttress it with some extra tissue, and then put large bore chest drains. I remember one of my senior colleagues saying, put 36 if you can, because these drains tend to clog. And obviously a gastrostomy, the drainage gastrostomy, and feeding jejunostomy to the patient. This was a patient who vomited who actually vomited after an endoscopy due to GI obstruction and some fecaloid contamination inside the chest. When we opened, we had prepared the intercostal muscle to repair the perforation under the distal esophagus. The patient, unfortunately, although the leak was sealed, the patient didn't survive the septic episode. So to reinforce repair, you can use many, such as intercostal muscle, pericardium, diaphragm flap. Diaphragm flap can be done, especially for the lower esophageal perforations. The pleural flap has been described by Dr. Grillo, especially if the pleura is very thickened due to inflammatory reaction. Momentum can be pulled up, pericardial fat pad and exothoracic muscles such as serratus can be done for upper esophageal or middle esophageal perforations. And again, let's not forget the main principles: the mid drainage, controlling the leak. We expand the lung, and obviously we need to feed the patient with jejunostomy, prevent the reflux with a drainage gastrostomy. All of these patients get infected and some bacteremia, even septic shock. And drainage of loculations is also important because there will always be some loculations as the body reacts extensively to any GI secretions in the pleural cavity. If you do an exclusion diversion, that's another story, especially if the esophagus is not salvageable. Then a cervical esophagostomy is performed, and you try to keep it long with under the clavicle and divide the stomach, and especially reinforce the stomach with omentum, and put a gastrostomy and a feeding jejunostomy. If it's an exclusion diversion, you don't do the gastrostomy, but you do a feeding jejunostomy and mediastinal drainage as well. This is a paper from Dr. Freeman, who was one of the leading experts in use of stents in esophageal perforations and leaks. You can see that they compared operative repair to stent repair in 30 patients each. You can see that the ICU stay is much less in the stent patients, where the total length of stay is much better. You can see the oral intake was much faster, and the early nutrition after discharge was possible, and term nutrition after discharge was possible in the stent group. But you can also see that the morbidity was also very high in the operative repair group as well. But this is a nice second table that shows that the patients who had stents were actually needed VATS in 60% of the patients, whereas the other group had needed a jejunostomy and gastrostomy, and a nitinol, especially a nitinol self-expandable metal stents were used in 60% of the patients. And you can see that the stent developing time was over 1.5 months on average. And when you look at the details of these procedures, they usually need more than one, sometimes 2-3 interventions in the 2-3 interventions in replacing the stents or fixing the stents to prevent the leak. Endoscopic clipping was used, especially if the leak was less than 15 millimeters, and actually over the scope clip was the winner of World Cup of Endoscopy in 2014. And you can see this paper in 2016 with 5 Bohrhaar with limited role, but still can be used in small defects. Endoscopic vacuum therapy was defined from Germany. Endoscopic endoluminal vacuum treatment with 5 in Bohrhaar. Complication rate was quite high. When you look at the literature, 10% is the major complication rate, and these include sometimes an erosion to major vascular structure, such as even the aorta and fatal bleeding. Obviously, the sepsis is prolonged, and empyema can go away, but it takes time if the sponge works well. The mean hospital stay was very long, almost 50 days, and they need to be changed every 3-4 days. But in this report, it was 5.4 sponges with a treatment duration of 19 days. You can see these algorithms. There's so many in literature. All of them depend on a contained and non-contained group. Most of them has the same thing. So if it's a non-contained, if it's early presentation, you do primary repair. If it's late, then you do T-tube fistula. Or if you are a GI, if you are a person with experience in the endoscopic vac treatment, then you just say if it's a vital mucosal open infection, you just sponge, and it's an intracavitary. And if it's, again, you can do an intraluminal. And if it's necrosis and severe disseminated infection, you combine acute treatment with surgery. And if you look at this, if it's a healthy esophagus and a confined perforation, again, it's a small one, it's a conservative leak. If it's a large leak, it's a primary repair. If it's unconfined, again, you look for ways to primarily repair it. If it's not possible, then you do an esophagectomy. And if there's an underlying disease, usually these patients get esophagectomy. And if it's a malignancy, stenting is one of the options. And again, when you're preparing this, this is another thing, early diagnosis, it's contained, no sepsis, conservative. It's contained with limited perforation, less than 2 centimeters, and a clip if less than 1 centimeter. Over the scope clip if less than 2 centimeters, but when you look at the literature, usually 15 millimeters is the limit. If it's a large defect, then a surgery plus interventional stenting. Again, a late diagnosis is pretty much same mentality. And
I don't hear anymore.
and if there is mediastinitis or not. And if there's not severe mediastinitis, usually primary repair is the preferred method of treatment. And you can see another thoracic abdominal perforation, again, divided with healthy and diseased esophagus. So this is a nice paper from Denmark, which shows that most of the patients who have perforations, most likely cervical or intra thoracic, they first go to surgical gastroenterology or stroke. Most of them don't come initially to thoracic surgery, but eventually they come to thoracic surgery. The primary treatment is usually none
I don't hear anymore.
or some conservative management. And this hasn't changed much over the years.
Okay, we have a problem with the internet connection of Dr. Batirel. I just tried to get him online again. I'm very sorry. Just a moment. I'm just trying to get him back online. So he's trying to reconnect right now. In the meanwhile, if you have any questions, you can ask them in the questions bar. Then we can ask them to Professor Batirel from the moment he's back. So for everyone who subscribed, this can be watched in delayed version. Okay, he's making connection again.
I'm sorry, really, for
No
this.
problem. No problem. You're back.
So where was I? So Liban, where did we leave? Did I disconnect after?
You can, if you just show your slides, we can see where we were.
Let me start here with the clipping. Is that okay? Did you hear the?
Yeah, the over the scope clip, we have seen this.
Okay, so I will do with the conservative approach, okay?
Mhm.
And then I will just. Okay. Okay, so I will just, I'm sorry for this connection problem. And I don't know if you heard about this, but um, just a reminder that patients eventually come to thoracic surgery unit. You can see that thoracic surgery, um, when they go to the primary treatment, it's no treatment or conservative treatment, and eventually they come to the thoracic ward and they need an operation. And this has not changed over the years. A conservative approach is limited with intramural perforation. You need broad spectrum antibiotics, stop the oral intake, and then perforation is limited to the esophageal wall on CT scan. And 7 to 10 days later, a contrast study um, shows no leak. The patient can take oral intake. So conclusions and tips. We obviously need to diagnose them early with good assessment of the patient. And cervical drainage is the most important. Most of the patients will be treated with just drainage alone. It will take some time to seal, but it will seal eventually. In thoracic, if it's small, especially less than 15 millimeters, can be clipping or stents, especially if it's about 2 centimeters. Yeah, and if they are diagnosed later with mediastinitis and sepsis, you can prefer the treatment based on primary T-tube vacuum therapy, exclusion, diversion, or even esophagectomy. But if it's less than 24 hours and if it's a large perforation, usually a primary repair is also very rewarding in the results. Drainage and conservative therapy is limited to, as I've told, just a localized infection or without any systemic septic treatment, septic condition. So prepare for long hospitalization and infectious complications and nutritional issues. So stage them accordingly and feed the patient accordingly. Just open a jejunostomy in the optimum time period. So now I'm going to move to anastomotic leak. I think it's one of the most dreaded problems. The easiest definition is an iatrogenic GI perforation, but it is not described like this. You can see Dr. Leroux describing in his first as clinically minor leak and a clinical major leak. The minor leak was local inflammation with cervical, such as cervical wound or an X-ray contained leak with fever, white blood cell increase, CRP increase, and in clinically major was severe disruption and conduit necrosis was described as an endoscopic confirmation. And you can see Dr. Beresford's classification as a simple anastomotic leak, as a conduit tip necrosis, and a complete conduit ischemia. But esophageal complication group actually developed an anastomotic leakage definition after esophagectomy. Anastomotic leakage has a multifactorial etiology, with tissue perfusion seems to be a pivotal role in leakage development. An ECG system defines it as a full thickness GI defect involving the esophagus, anastomosis, staple line, or conduit, irrespective of presentation or method of identification. And these are the 3 types. You can see the local defect, again, local defect, but needs an interventional radiology. This doesn't need any treatment. And the local defect needs surgical therapy. And the next one is conduit necrosis with focal identified endoscopically or focal identified endoscopically, not associated with free anastomotic conduit leakage, and the third one is extensive. But when you look at it, there is some vogue descriptions such as local. Well, how do we define local? Is 1 centimeter local, 2 centimeter local, 3 centimeter local? And you will now see that some other definitions which also have some vogue terms. This was a nice survey that showed how we define the leak and how we manage it. You can see that many surgeons participated from all over the world, and you can see that there is no consensus in terms of the post-operative management and post-operative interventions, such as CRP being done only 50%. Just a complete blood count is performed by 80%, and 50% perform chest X-rays. And when you come to POD5, only 21% of the participants were performing a chest X-ray, and relatively throughout the 7 days, almost 50% was performing CRP. And a CT scan was rarely performed. Some of the surgeons continued to do barium swallow or contrast swallow at the 7th day. And if a leak was diagnosed, what was the first thing they did was laboratory in 55%. A CT scan was 45%. Endoscopy, which is the recommended one usually, was 25%. And a CT and a barium swallow was about 50% again, as the first choice interventional method. And you can see now this ECCG classification of anastomotic leakage, what you see: local defect requiring no change in therapy, localized defect, and a localized defect. So the terms that are being used sometimes may not correspond to what we see in the clinic, and thus there is a need for more use of algorithms and developing algorithms in the management of this difficult condition. And you can see the management of anastomotic leakage when you see it obviously changes based on cervical and thoracic leaks. And when you see the cervical leaks, most of them are managed by just opening the wound. And if it's an intrathoracic leak, endoscopic stent placement or radiologic drainage comes to the front. And when you see if there is a type 3 leakage, which means relatively some degree of conduit necrosis, disconnecting the gastric tube is especially preferred in almost all series if there is gastric conduit necrosis. And in the mediastinal manifestations, surgical drainage is the preferred one. So when I'm talking about the leak, I will most focus on esophagus and gastric conduit. Colon or jejunal pharyngeal leak are completely different situations, and they will need some different topic. So just okay, so why shouldn't we have a leak? It's important not to have a leak because when you have a leak, the patients survive much worse. So intrathoracic anastomotic leak was independently associated with a higher risk of recurrence and all-cause mortality. And you can see that the anastomotic leak changes between the series, with the randomized study by BR showing 7 to 12%, 12% in the minimally invasive group. And the Dr. Lukic's series in over 1,000 patients had a leak rate of 5 and 4%. Obviously, it's related with experience. This was a nice report from Brigham in February 2019, which shows zero leak and zero mortality in the last 40 patients out of 170. But still, in the beginning of the minimally invasive experience, the leak rate was almost 10%. and the morbidity was about 50%, and they all came down to 40%. Number of lymph nodes increased, and admission rates, 90-day readmission rates, decreased as well, and these were significant. So let's come to question 4 and 5, which are pretty much the same. But what should be the leak rate following an Ivor-Lewis esophagectomy?
So I just wait.
Yeah.
For question 4 and 5 together. What should be the leak rate following Ivor-Lewis esophagectomy? And then the next question would be, what should be the leak rate in esophagectomy with cervical anastomosis? Maybe some people can have an extra vote, because I don't have a lot of votes for question 4 yet. So you can do both.
So the first one was Ivor-Lewis, which means intrathoracic, and the second one was a cervical anastomosis.
Okay, and there the answers are quite mixed. Let's take question 4 first. So the Ivor-Lewis esophagectomy, there half of the people are saying between 5 and 10%, and the other half is saying less than 5%, and small minority is saying that it could be more than 10%. And in the cervical anastomosis, we see 35% saying less than 5%, then almost half of the audience saying 5 to 10%, and 50% of the audience is saying it can be between 11 and 15%, and almost 10% of the audience is saying up to 20% is acceptable. So much higher in cervical anastomosis than Ivor-Lewis.
Well, obviously, when we look at it with Ivor-Lewis esophagectomy, I think it's up to 10% based on the literature. Better to keep it less than 5%, but it is not in the initial minimally invasive most series. The leak rate was a little higher, excluding Dr. Lukatich's experience. And for the cervical, obviously, the leak rate is higher because the conduit is longer. So the perfusion of the tip of the conduit is not as well as an intrathoracic anastomosis. So most of the series reports a leak rate of about 10 to 12%. Well, there's no future without lessons. Dr. Sweet in 1950 said, especially from the technical standpoint, we need to avoid tension. We need to avoid a traumatic. We need to do a traumatic handling, so no trauma to the conduit. We need to do interrupted sutures, which means in this era, a good choice of staplers. So if you have a thick gastric tissue, if you use a blue stapler, then that may cause some tissue damage. So you sometimes use purple or sometimes green based on the tissue quality. And if you need to reinforce the staple line, just you do the reinforcement. And you need to make sure that the mucosa is nicely approximated, whichever the technique you use. And you can see in this nice report of only 23 patients, but it's a nice study. They had a leak rate of 26%, 6 patients had leak. And what you can see is when you form the conduit, when you cut the short gastrics, the saturation of the tip of the conduit drops down to 89. When you divide the left gastric, it goes down to 75. When you complete the conduit, it goes to 71. And when you pull it up, it recovers a little bit. And when you see those patients with anastomotic leak, it's almost 100% with no complication group or no anastomotic complication group, whereas it's about 70% with the anastomotic complication group, that which obviates that there is some perfusion issue with the conduit. And this was also proved by showing that if you do some ischemic conditioning, the conditioning group did much better in terms of saturation of the tip of the conduit. And ICG has been also used for assessment of the conduit perfusion, but it just shows the integrity of the vessels. it doesn't show if the vessel is perfusing enough blood or not. It doesn't give you any idea about the saturation, the top tip of the conduit. We use it now routinely as well, but it just shows that the vessels are actually, the contrast is being carried to the tip of the conduit, but it doesn't mean if the perfusion is enough or not.
Mhm.
And there is an assessment of the conduit thickness as well. You can see a narrow and wide, and in this study, a wide conduit was associated with almost 2 times the leak rate. It was 70%, 17% versus 9% in the esophagectomy group. How about the anastomotic technique? This was about over 400 patients from Mayo Clinic, which showed that the linear stapler was the best, 8% with circular stapler, whereas modified colored and hand sewn had a leak rate of almost 20%. There are some systemic factors such as malnutrition, intra and postoperative hypotension, hypoxia, diabetes, drinking and smoking habits, and a postoperative Carlos leak and loss of proteins are important. And this has been another study in 2014 which showed that if the anastomosis is within the radiation field, there's a highly likelihood of leak, whereas if it's not, then it's much better compared with the in-field anastomosis. So let's come with the next question. It's a 76-year-old male. Now we have more patients coming with a lot of comorbidities. We had several patients with prior bypass. The patient had a GEJ adenocarcinoma. There was an esophageal. This is the discharge chest X-ray. So it looked pretty good with a little bit of mediastinal widening, I would say. But the patient didn't have much complaints. Eventually had a cough on oral intake on day 8, just 1 day after discharge, and an oral contrast revealed this. There is a hole in the left main and a leak in the esophagus, just at the edge of the anastomosis. So which of the treatments would you prefer in such a patient?
So you can vote again.
I don't know if the voting is going on.
Well, we have about 1/3 of the audience already voting. So I wait a few more seconds.
Okay. I'm sorry for the interruption. Really, it has been. But I hope the overall thing is going well.
It's okay. We still have a lot of people watching, so
Okay.
it's interesting. We see that the first option, thoracotomy repair with omental reinforcement, is in favor of 40% of the audience. About the same, 36% of the audience is saying double tracheal and esophageal stent. So these are the choices of preference. And then about 15% saying esophageal stent and bronchial suturing through VATS. And only 5% is saying esophagostomy and gastric exclusion.
Yeah. So as the patient had a bypass, although had a minimally invasive esophagectomy, the patient, we said, would be too morbid to do any thoracotomy, so we did double stent. The patient had a very large esophagus, so that was the reason we were able to put double stent and not cause any erosion in the between the esophageal wall and the tracheal left main bronchus. The patient needed at least 5-6 times of endoscopic intervention, clipping the stent so that it doesn't move in the esophagus. And for the tracheal stent, it remained in place. Actually, we put 16 and then we 16 millimeter, and then we put an 18 because the patient had very large trachea as well. But eventually, the patient was controlled and the stents were removed 4 months later with complete healing. And this is the recent chest X-ray afterwards. And now let's come with another patient. This is a patient, 29-year-old female with GJ adenocarcinoma post-chemo radiation, very young, unfortunate lady, had an Ivor-Lewis esophagectomy with a CRP level high on POD4. Leukocytes were at the upper limit. There was subfebrile fever. And what would be your strategy? You can see the CT scan and you can see the chest X-ray. So I hope you can see the voting.
So it's a quite early leak, but just fever in the leak seems to be contained because it's not touching the drain.
Yeah.
And this is being a close call, I think. So about 20 to 25% is saying, oh, it's jumping over each other now. It's a close call. 1 in 3 is saying right fats exploration and repair of the perforation. And all the rest is actually about 25%, saying 20 to 25% is saying nilparos observation, left fats and esophageal stenting, or endoluminal vac therapy. So there's few more percentages for the right fats exploration, repair, and perforation, but for the rest, all options seem to be possible for the audience.
Yeah, so it shows that there is also a lot of different approaches. Mm-hmm. So what we did to this patient, as you can see, we put a stent in. We did a left VATS and esophageal stenting. The main reason is because there is a containing, and it is, as you can see here, that's just the contrast is just on the left main bronchus, and you can easily have erosion of the bronchus if you leave that thing in there. So we did a left VATS and esophageal stent, and 3 months later we removed the stent, and she was one of our earliest minimally invasive esophagectomies. Most likely this was a technical error with the anastomosis, and she's now in her 9th-year follow-up. How about the stents in anastomotic leak? Dr. Freeman, again, the champion of stents, showed that they had 100% almost success rate, but obviously you can see stent migration in 20%. We also see the same thing, that with stents there is almost 30-40% chance that you may need to re-intervene and make sure that the leak is sealed. This was an esophagectomy that we had done with a normal barium on day 7, and then day 9, a sudden leak on the right side, and there was a conduit necrosis, and that we had to do an esophagostomy and eventually a retrosternal colon interposition. Again, another one, most likely this was that I shared during the ESTS meeting this year. This was a relatively recent patient with ICG poor perfusion during the formation of the conduit. The patient had almost a malignant hypertensive episode before the esophagectomy, and the patient had significant conduit necrosis in the upper half of the conduit, so we did an esophagostomy, and eventually we did a retrosternal colonic interposition 2 months later, but the initial exploration was VATS. I'm just finishing with a couple of slides to give some tips. So subtle signs of leak. One of them, especially if you have a cervical leak with intrathoracic extension, one of the initial signs is a small apical pneumothorax and a mild air leak despite you didn't touch the lung intraoperatively. If there is a leak in the pleura, despite the lung is very healthy intraop and you didn't touch the lung, we always check if there is a GI injury or not, whatever the patient's clinical status is. If there's an unexplained infiltration in the lung or pneumonia, again, it's a sign of leak. High chest tube output is either chylothorax or leak, and checking the amylase may be helpful in those patients, especially if the color of the chest tube is still serous. Sometimes if the hiatus is very large, abdominal fluid can also increase the duration of pleural fluid output high for several days. Mediastinal widening without pleural effusion is also alarming, an elevation of CRP following oral intake, although there is no sign of leak on chest X-ray, is also there subtle signs of leak. And nowadays, what we prefer is if the patient has this limited cardiac function or elderly or had bypass or 80-year-old patient, doing these patients laparoscopically means doing a reverse Trendelenburg, inflating the abdomen, exposing them to DVT plus hypotension at least for 20-30 minutes. So if you do the same thing with a laparotomy in 1 hour or half or 45 minutes and keep the blood pressure stable during that period, most likely the morbidity of the laparotomy is much less compared with that blood pressure assault during the esophagectomy. So we prefer to do laparotomy in high-risk patients that we deem risky in terms of pressure. And perfusion of the conduit can be assessed with ICG, but we almost always keep the systolic blood pressure over under 20. We remind our anesthesiologist intra and post-op, and we actually, in some of the patients, continue with the inotropic agents, noradrenaline, for 4 or 5 days and keep the blood pressure, especially in hypertensive patients, over under 20 to keep the gastric perfusion in an optimal level. And this was assessed by, it was a very recent paper by Dr. Lowe, and you can see that they try to keep the blood pressure by giving fluids, decreasing the epidural rate, and actually assessing the patient very frequently that the patient has enough intravascular fluid and the blood pressure is high, so the perfusion of the conduit. And they actually aimed for a mean arterial pressure not less than 70, but I think in most of the patients in the elderly, you need a blood pressure of systolic over under 20. Some more, if it's an intrathoracic leak with effusion and signs of sepsis, that's an urgent situation. If it's an intrathoracic leak, loculated but stable, may work drainage plus stents most likely. If it's an intrathoracic leak and it's just mediastinal, just seal the leak with a stent or clips if you need to, give NPO, wait, and be careful for any bronchial erosion. There are some rare presentations, such as I've showed that the mediastinal leak can be without any pleural contamination. And we had seen a few cases with lung abscess, especially after 10, 15 days, most likely a very small stapler defect or erosion to the lung tissue, and then you end up having an abscess cavity, and the patient coughs every time he or she drinks something, and that's most likely due to stapler erosion. So in conclusion, and take-home messages, keep the blood pressure high, intra and post-op. Perfusion is everything, as this has been proved. Diagnose them early. Do not neglect small signs. We get an early CT scan even in the first 24 hours if we suspect anything technical or something. And the brain amylase can be helpful, especially in a borderline situation where the fluid is not much, but the color is kind of changing and you are not sure if it's over under 25 to 250. Usually it's in the thousands if it's a significant leak. Seal the intrathoracic leak ASAP. Sometimes small leak can become big and pneumonia is always the result. And if it's not sealed, I'm not sure we should wait. You need to eliminate the leak, otherwise the patient is in the ICU for a long time. Septic episodes, bacteremia, sepsis, multiple antibiotics, and eventually very high mortality. Thank you very much for listening to me for this long talk. I'm sorry for the interruption, and I hope it has been of help to everyone. I'm happy to answer any questions.
Thank you very much. We do have some questions in the meanwhile. If we just go to the questions poll and we start from the bottom, we have the first question. Do you sometimes recommend surgery plus stent at the same time?
Sorry, I'm sorry.
Do you recommend surgery plus stenting at the same time?
Well, there are some reports, and in some cases, surgery and stent can be used, especially if you are not sure that your repair may dehisce after surgery, if the suture line is not very strong. There are some reports that you can put stents after you do the surgery and just place a stent. But Honestly, in case of a leak, and if they need a thoracotomy or a surgical repair, these patients usually are not in a very good condition. They are either bacteremic or in the early phases of a sepsis. And if you keep the operating time too long, that's one of the problematic things. So try to keep the operation time as short as possible. Do the appropriate procedure and get the patient get the patient to the ICU and get them to normal perfusion and waking up and eventual extubation, because long operating times are also associated um, with negative effects.
Mm-hmm. Then a question in the same range. What would be the strategy for perforation an esophageal rupture of more than 24 hours old in an old patient, more than 70 years old, with the bilateral pleural effusion? Same problem, I think. Do you consider major surgery or something else?
I think it depends on the condition of the patient. If a 70-year-old patient who's in a good condition would probably deserve an aggressive approach. I mean, if there are not much comorbidities, the patient is alive, otherwise, the patient is in a well-to-do condition, otherwise, not many comorbidities at all. And if it's more than 24 hours, still, it depends. In some of the patients, if it's more than 20 hours, 24 hours, and the patient ate all the way, there's a lot of food contamination in the chest, and that's a different situation. But if it's 24 hours without NPO, then it's a different condition. I mean, if you see the patient in 48 hours with no oral intake, was observed in a primary unit and then a secondary, and eventually referred to your unit, that patient may most likely benefit from a primary closure and reinforced with muscle or some reinforcing with tissue. But the other patient with severely contaminated chest, that's a really different issue. Uh, as I said in my final thing, if you don't seal the leak, the patient is unlikely to survive. The leak should be contained because even the smallest leak leads to contamination in the lung and pulmonary sepsis. You end up having a pneumonia, and think about, most of our cases are now chemoradiated. If you have a chemoradiated patient and that chemoradiated lung exposes to GI secretions and most likely a GI flora, then the pneumonia in these patients are very severe as well.
Mm-hmm.
So that's probably one. So early sealing the leak, whatever the admission time is, I think the primary aim is to make sure that this leak is sealed.
Okay. Considering cervical or upper thoracic operations, in which situation do you think double vacuum therapy, so from the inside and the outside, from the neck, could replace traditional surgical approach? Do you have any experience with that?
Well, we used WAC in a few patients, but they were actually, I think, very sick, so they didn't benefit much from the treatment. But honestly, with the VAC treatment, I think there is a need for experience. But you can see in most of the reports that VAC patients were in the hospital for over 1.5 months or 1 month. So, I mean, if the patient doesn't have any contraindications, I usually prefer to eliminate the leak somehow, either through an exclusion and then doing a final reconstruction. But let's think about the patient that we had with the bronchial perforation. You need to think many things. In a patient with bypass, there's no chance that you can do a retrosternal reconstruction if you exclude the patient, because the patient had a sternotomy. So in those cases, you try to stay as minimally invasive as possible and make sure that the patient is appropriate. In that case, for example, if the conduit necrosis was very significant, we would most likely do an gastric exclusion and a esophagostomy and open a jejunostomy to see for a while, for a long time, and then most likely do a reconstruction. But it's a very tough situation as well. Just to save the life of the patient was the initial thing that you would do.
Okay. What do you do in case of esophageal perforation in the area of cicatricial stricture after a chemical burn? Are you considering conservative treatment in this case?
Yeah, that's a tough situation as well. But I had a couple of patients like with achalasia, multiple operations with distal perforation and then repair, and eventually we did them an esophagectomy. And what we found was there was actually a fistula between the parenchyma and the esophagus. So the patient healed from the perforation, but healed through pulmonary contamination. So if the patient has a stricture, most likely this stricture is secondary to caustic intake or caustic burn. And if this is a caustic burn, I would probably go for that patient, depending on the time of admission, to an esophagectomy or stage repair. First do an esophagectomy, and then eventually do a repair.
Mm-hmm. So the serum, the MLS in the pleural serum level, we already talked about that.
Yeah.
This most likely more than 150 or 250, but more in the thousands. Then a question from Bartosz Kubisa. Do anybody in Europe use esophageal exclusion treatment with 2 staple lines on the cervical and just above the stomach? Do you mean any? Yeah.
I think that's that. I've learned from Dr. Tony Lorut there was a mucosal esophagostomy. I had heard that you expose just the mucosa, but not the muscle as well, but to actually preserve the esophageal line. But I think it's very easy to do an esophagostomy. It's not difficult. So doing an esophagostomy just over the clavicle or on the or just below the clavicle or at the clavicle level is very practical and actually gets the patient to the safe zone, because you don't have any more pleural contamination with oral flora. Our mouth is the dirtiest part in the body. And don't forget that amylase is a very strong enzyme that degrades the tissues. And if you leave amylase plus oral flora contaminating the chest, there's always long-term problems. I mean, we had even in some of our cases, I remember we had pulmonary bleeding, aortic bleeding in some of very rare cases, twice in our experience.
Okay, many more questions I see. Imagine you open a patient because of a large rupture and you see that a lot of muscle is actually missing. You only have mucosa left. Would you try to repair the mucosa, or what would you do, or would you go for an exclusion?
Well, I would most likely go for an exclusion. And if it's just mucosa left, I mean, you will always sometimes, even the shortest esophagus would be able to be opened just on the side of the cervical area. I mean, if you don't have a long esophagus, still you would have at least 1 to 2 centimeters of esophagus left that you can actually turn to the side and just do the esophagostomy on the side of the sternocleidomastoid muscle.
Mm-hmm.
I think it's possible.
Okay. Then to prevent anastomotic leaks, do you prefer circular staples or sutures for the anastomosis? I think there's a lot of discussion on that.
Yeah. I think the technique is not important, but sticking to the perfusion and the ease of the technique is important, and not beating up the stomach or esophagus much. Mm-hmm. Be careful not to injure them.
Indeed. Using amine to guarantee higher blood pressure, except when mandatory, shouldn't be contradictory in maintaining good visceral perfusion. I understand that indeed, if you need a lot of noradrenaline, then maybe your mean blood pressure will be high, but maybe the perfusion in the stomach will not be. What is your?
Well, that can be discussed, but we give very low dose. I mean, usually in the very low dose, you can be able to perfuse. Usually, dopamine is worse for peripheric vascular constriction, vasoconstriction. Noradrenaline usually is a more systemic. It works with the cardiac contractility. So I think it's much better for use in the postoperative period. But usually they need a very low dose to maintain that blood pressure, very, very low dose.
Another interesting question, I think, is what is the preferred management in case of post-achalasia pneumonic dilatation perforation?
Yeah.
So conservative stent or surgery after achalasia?
Yeah, a couple of experiences. One, we had a perforation secondary to our surgery, a hilar myotomy. We did a T-tube in that patient to survive, but that was an abdominal perforation. And we did a T-tube to survive the esophagus in a young patient with achalasia. This was many, many years ago, I think almost 8-9 years ago. And the second is we had a huge achalasia, achalasia plus esophageal motility problem. We did a myotomy, and then there was a perforation. The esophagus was dilated. We did an esophagectomy. That leak would not heal at all. Esophageal esophagus is, especially in an achalasic esophagus, if it's megaesophagus, it will not heal. So you need to do an esophagectomy.
I also think it depends on where the perforation is.
Absolutely.
In our experience, most of these perforations are really low or in the abdomen, as I said in the first patient, and then you can go quite conservatively because the omentum will do something. But if it's in the chest, in an esophagus that doesn't have any strength anymore, it's going to be very tough. Yeah. Other questions. What would you suggest as a treatment for thermal damage to esophagus during non-esophageal thoracic surgery?
Yeah. Depends on the time. You can have with harmonic or with cautery, you can have, but it depends. You need to treat it like an esophageal perforation. It's an iatrogenic esophageal perforation, and if the tissue is live, you primarily suture it, diagnose it early, and just go ahead primarily suture it and reinforce it. If you diagnose late and the patient had oral intake, then you behave accordingly as well.
Another thermal damage we every now and then see is after radio frequency ablation of the veins for atrial fibrillation. So this can also be a nasty thing which can give some fistulas to the heart as well. Is there also option to pull the conduit subcutaneously in the patient after bypass if needed?
Yeah, it is, but we don't. Well, I thank my friend Miroslav Yanik, who is very experienced in esophageal surgery as well. It can be done, but subcutaneous route is the final option that we rarely use, I would say.
So do you use VAC therapy to seal a rupture?
I think we already talked about it. You can use, but we don't. I don't have much experience with the VAC therapy, but honestly, I do not think for 50 days of hospitalization is a good option. Other than those patients who will not tolerate significant esophageal intervention.
Okay, one last question then. If you have a large leak after 5 days of an Ivor-Lewis esophagectomy and you decide to perform a thoracotomy and you find necrosis of a few centimeters, what do you do? Do you perform a re-resection of the necrotic segment and go for a new anastomosis, or do you, I think, go for an for an exclusion?
I thank Marcelo for this good question. I think it depends on the observation. If the esophagus is very healthy and the type of anastomosis you do, we do a side-to-side anastomosis, which causes a long staple line. So if you do an end-to-end anastomosis, I think that can be done. You can divide the esophagus from a healthy segment, and if your conduit is of relatively good length, you can divide the conduit from a healthy margin and anastomose them together. But in most of the cases, one of those is not in a well condition. So in such a patient, if there is, I would say, 3-4 centimeters of necrosis, it's most likely the best treatment would be, if the patient is going for sepsis, to go for exclusion and a reconstruction afterwards. This is a very debatable issue.
Okay, thank you very much. We had a great ESTS webinar, I think, with more than 160 live attendees, many interactions, as we have seen. So on behalf of the ESTS Learning Affairs Committee, I would like to thank you, Professor Batirel, for the excellent webinar today. You, of course, the audience, for your interest and interaction. I hope to see you again next month for the webinar on non-intubated thoracic surgery with Professor Pompeo and Professor Dauri from Rome, Italy. Thank you again. Do not forget the questionnaire, and see you next month.
Thank you very much.